Hello and welcome at another episode of EAO Just Ask Live, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop and I'm the host of this EAO channel, and tonight in this live video session we will try to answer all your questions about soft tissue management around failed implants. And to do so, I'm very honored to be joined tonight by Professor Martina Stefanini, live from Bologna in Italy. Martina, good evening.
Good evening, Gerrit. Nice.
I'm so happy you're with me. You are a professor in periodontology at the University of Bologna. You're an active member of many of the associations, dental associations in Italy, and also a very active member of EAO. For those of you who think that Martina looks familiar to you, maybe you were part of the EAO digital days where, Martina, you were part of the famous Prime Time Debate 4. How do you look back at that experience?
It was a super nice experience, and it was amazing to share the podium with many famous colleagues. And will never forget the experience with Marcus Ulzer, as what
Exactly.
is related to the gymnastic exercise. Can
Exactly.
you
Let's see if we have some gymnastics tonight. Now, for those of you who have good memories of the Papilla Challenge, you might know what we're thinking about. For all of you who have no clue what we're talking about, let me invite you that if you consider a membership of the EAO, have a look for that at eao.org, you will get access to all the recordings of the EAO digital days. They will be available for you in the online library, which is just one of the many benefits of an EAO membership. So check it out either after this session tonight or perhaps tomorrow. Now, I already see some nice chats from all across the globe. People saying hello, checking in. Brenda Mertens from Montpellier. Alfonso Gil from Switzerland. Go Martina, he says. Lucas Wa tuning in from Germany. Mustafa Hussein live with us from Iraq. So if you now just join us, let us know in the chat panel on the right side where you're joining us from. And for those of you who are here for the first time, let me explain. We will have a short introduction, just introduce the topic, what are we talking about tonight together with Martina. Then next up, or in the course of that, we have received two cases prior to this session, which we will then answer to the best we can. So people have submitted their questions to us. And then in the last part of this session, it's just fully open mic night. If you have any questions, please submit them via the live chat and we'll try to answer as many as we can. So Martina, are you ready?
Yes, ready. And I'm
Yes.
very happy that we have a lot of friends from all over the world listening to our talk, our chat.
Exactly. Well, let's start at the very basis. We talked tonight about soft tissue management, and then the second part of the title is around failed implants. What do you mean when you talk about failed implants tonight?
We are talking about failed implant from an aesthetic point of view. And let me share minutes my screen because I want to show you what I'm speaking about when we speak about failed implant. These
Mm-hmm.
are aesthetically failed implants. Uh, and what I would like to underline is that unfortunately in literature there's still not a definition regarding what is a failed implant from an aesthetic point of view. Because in some publication, the author described a failure implant only when there is the implant thread exposed. But if we think from a patient point of view, for example, we know that it's of paramount importance to have the same length of the implant supported crown and the adjacent natural tooth. So we can define a soft tissue dehiscence around the implant as an apical shift of the soft tissue margin of the implant supported crown with respect to the adjacent natural tooth, independently from the exposure of the implant thread, because you can have a failed implant and an aesthetic problem for your patient also if you don't have the implant thread exposed. So we are speaking about this kind of defect around well osseointegrated implant with an apical shift of the soft tissue margin, because the final outcome is to obtain a complete dehiscence coverage, because we want to reposition the soft tissue margin of the implant supported crown at the same level of the homologous natural tooth in order to obtain again a nice alignment of the gingival margin. And we need also to increase the soft tissue thickness of at least 2 millimeters. This is one of the most important aspects when we speak about soft tissue dehiscences around implant, because we need to increase the soft tissue thickness to mask the transparency and to prevent soft tissue dehiscences recurrence over time.
Exactly, very clear. So that is what we talk about tonight when we mean failed implants, focusing on the aesthetic and focusing on the levels of soft tissue, both in thickness and in margin. Now, when we talked a little bit last week, and I asked you what is the key things that you want people to learn from this session, the one thing you mentioned immediately is to better understand which defects you can and which defects you cannot treat. Well, let's start with that. Help us out. What is the clear guidance there?
Exactly, because the most important things to understand is that we are speaking about implant without any signs of mucositis or perimplantitis, because we are speaking of buccal soft tissue defects without in a very well osseointegrated implant without any signs of perimplantitis. And this is of paramount importance. And if you look at the CBCT of this case, you immediately realize that the implants are completely buccally displaced, but the interproximal bone peak in the or intraoral X-ray is in the right position without any interproximal bone loss. And what is of paramount importance before starting the surgery in this case is to probe on the buccal aspect. Because in the buccal aspect before the surgery, if you don't have any probing pocket depth and any bleeding on probing, it means that there is no signs of perimplantitis or mucositis on the buccal aspect. And when you will elevate the flap, you will find above the implant thread, despite they were exposed because of the buccal displacement of the implant, you will find this that is called connective tissue adhesion that cover the implant thread that were not exposed to the oral cavity because they were not probable before the surgery. So this is one of the most important aspects. We are speaking about healthy implant from a bone point of view on the interproximal side and without any contamination of the buccal thread. The second limits of the treatment of these kind of defects is when you have an implant which is excessively buccally displaced, associated with the lack of interproximal soft tissues. In this case, like the one I show you, where the papilla are more apical with respect to the ideal position of the gingival margin, I'm sorry, but I don't have any surgical tip to treat this kind of defects.
And this is, Martina, we cannot treat this case because there's simply not enough soft tissue to start with.
Exactly, because the interproximal soft tissue are more apical to the ideal position of the gingival margin. So you don't have the interproximal vascular supply for the coronary advancement of the flap.
Clear.
Associated with an excessive buccal displacement of the implant, because the implant malposition is the most important predisposing factors for soft tissue dehiscency. The second aspect, always related to the implant malposition, is when the implant is positioned with a bad angulation. And thanks to this new welded angulated abutment, we can treat implants which have a bad angulation, but less than 40-45 degrees. When we have an implant which is angulated, bad angulated, more than 20 degrees, 40 degrees, we cannot treat it because it is impossible to correct this bad angulation with an angulated abutment because it's too much. So this is the second case that doesn't allow to treat these soft tissue defects. And Another very challenging situation is when there is an error in the mesiodistal implant positioning. And what I would like to underline with you is that in these cases, we don't have to look at the X-ray because the intraoral X-ray in this area is not the right radiographic exam, because there is the distortion due to the curvature of the palate in this area. But we have to look at the soft tissue between the tooth and the implant. And if we have less than 1.5 millimeter of space between the implant and the adjacent tooth, we cannot solve these interproximal soft tissue defects because we don't have enough space for the soft tissue. So the soft tissue, even if I will remove the crown, I will reduce the abutment. If there is not at least 1.5 millimeters of space for the soft tissue, we cannot solve this aesthetic defect in this area.
Why is this such a limiting factor? Just because there's not enough room for the tissue to regrow or to do the surgery?
Yes, because if you don't have at least 1.5 millimeters for the soft tissue, they will not grow, and you will not have enough tissues also at the time of the surgical procedure to obtain a first intention wound healing, because you don't have the space available for the soft tissue. And the base of the papilla in this case is smaller than 1.5 millimeters and will not provide enough vascular supply for the soft tissue growth in this area. So this is another limit of the mucogingival procedure to solve this kind of defects. And I would like to show, this is one case that a colleague sent us before.
Yeah, and it's important, Martina, because it doesn't happen. It hasn't happened for a while. Obviously, these monthly Just Ask Lives are also inviting you to send in any specific cases up front, so we can put them in front of our expert. And Chris Cutchen has actually done this. This is Chris's case, and he is now getting his answer live. Yeah.
Yes, thank you, Chris, for your cases. It's really nice, and unfortunately, I cannot give you a suggestion to treat this case because we don't have one single implant intercalated between two natural teeth, but we have two adjacent implants, which are, you don't send me, unfortunately, the endooral X-ray, but just the panoramic, which doesn't provide the right quality of the bone between the two implants. But unfortunately, I think that there is not enough space between the two implants to recreate the papilla. And I'm a little bit worried to suggest you some surgical procedure to treat this defect, because the aesthetic is not so bad, and there is the risk, in case you perform a surgical procedure, to obtain a worse result than the baseline one because of the small distance between the two implants. So I don't think that you can do something to improve this case.
Aha, so this is again the limit of the distancing that we need between the teeth and the implant, or in this case, between the two implants.
The two implants, exactly, because it's easier to treat a defect when you have a single implant, but when you have two adjacent implants, it's much more complicated. And in this case, the two implants are too close each other. So this is one more aspect to take into consideration.
And are you saying, no, you just said I don't have enough information, so you cannot fully judge, but based on what you see here, because you say I would be very careful with even going into surgery.
Exactly. Because yes, the endooral X-ray is lacking. It sent me just the panoramic X-ray that doesn't provide a precise definition of the bone between the two implants.
Exactly. Clear. Well, thanks for answering Chris's question. I would say, Chris, if you're watching, let us know in the chat if this is helping you or if you need more information. And that's an invitation to everybody just joining. We see a lot more people. We see Mahmoud from Egypt, Zainab from Barcelona, Eleni from Cyprus, Navid from Nantes. We have Quico from Huelva in Spain. You see, we are live. If you have any questions to Martina Stefanini during this full hour, please use the fact that we are live. Martina, please continue.
Yes. So today I would like to describe briefly the approach to solve this kind of defect. And what is of paramount importance, is my opinion, in this approach is that it's a combined approach. It's not only a surgical approach, but it's a combined prosthetic and surgical approach. And this is the true secret of this approach, is the key to obtain a success. Because when you have a defect like this, you see that in the level of the mucosal margin of the implant supported crown is apical with respect to the adjacent natural teeth, and you see the alveolar mucosa is very, very thin. So there is, by transparency, the color of the abutment that is visible, and it is not nice from the patient. And if you look at the endo-oral X-ray, you see exactly what I told you before, that we are treating well osteointegrated implant without any signs of perimplantitis or mucositis. And our combined approach consists of this coronally advanced flap plus a connective tissue graft that should be positioned at the level of the ideal gingival margin. And if you look at the baseline situation and you imagine to position the CTG at this level, you immediately understand that you have a small amount of interproximal soft tissue. So even if you are the best surgeon ever, you cannot maintain the coronary advanced flap stable because you don't have enough vascular supply deriving from this small triangular shaped anatomical papilla. So you need to find a way, a solution to improve the quantity of interproximal soft tissue. So the only way is to remove the pre-existing crown, change the abutment and apply a narrow abutment and a short provisional crown. In this way, the soft tissue will grow and will occupy the space that was previously occupied by the crown and the implant abutment. So now, after, let's say, 2 months of pre-surgical prosthetic phase, you can see that the quantity of interproximal tissue is incredibly augmented. So now we have trapezular shaped papilla, ample enough to provide the right vascular supply for the surgical papilla of your coronally advanced flap that will remain in this coronal position and will completely cover the connective tissue graft in this ideal position at the level of the gingival margin of the adjacent teeth. And moreover, when you remove the crown and the abutment, you can also desepithelize the anatomical papilla toward the palatal aspect. So in this way, you increase the quantity of the desepithelized anatomical papilla that will provide the vascular supply for the papilla, for the surgical papilla of your flap. So this is the rationale behind the pre-surgical prosthetic phase. And obviously also the quality of the connective tissue graft is something which is of paramount importance. And at the end of the surgery, you have to obtain this completely covered of the connective tissue graft. And as you can see, the surgical papilla of the flap reached the occlusal aspect thanks to the absence of the crown. So if you look at this case, after the crown removal and the short provisional crown imposition, we can immediately understand the important role of this pre-surgical prosthetic phase. Look at the different shape of the anatomical papilla, small and triangular at baseline with the pre-existing crown, and ample trapezoidal shape with the new provisional crown and abutment. So this is the most important aspect of this combined prosthetic and surgical technique. And
exactly. Yeah.
no, yes, if you want, I can just show you the video of the surgical procedure if you don't have any questions from the audience.
No, we have just a lot of people checking in. Andre Chen joining us from Lisbon again, one of our premier guests. Michael Payet from Austria, Ahmed from Morocco, Guillaume from Montpellier. So people are checking in. But a good reminder, if you have questions about anything you see or hear or think, let us know in the chat.
So this is the surgical procedure. The flap is the trapezoidal shaped flap design, the same flap design that we apply in the treatment of gingival recession around teeth. And we started with the split thickness surgical elevation of the surgical papilla, and then the elevation of the central portion of the flap. In this case can be performed with the periosteum elevator because we have enough keratinized tissue in the flap, but in some cases, if we don't have keratinized tissue in the flap, we need to use the tip of the blade also in the central portion of the flap. Then we connect the vertical releasing incision split thickness with the central portion. And then we start with the deep split thickness incision to detach the muscles from the periosteum. You see, with this cut, I'm separating the muscles from the periosteum. And then I can perform the superficial split thickness incision to detach the muscles from the alveolar mucosa. And in this way, separating the muscles from the deep insertion and from the superficial insertion, they can shrink apically, and the flap remain made only of alveolar mucosa, which is rich in elastic fiber and can be coronally advanced. And then it's the time for the harvesting procedure. I place my connective tissue graft at the level of the ideal position of the gingival margin with the abutment. You see that the abutment now has the role to withstand the connective tissue graft, which is fixed at the base of the anatomic disepithelized papilla with single interrupted suture, and in the apical position with this external mattress suture, which is the thickness of this connective tissue graft. The thickness.
Yeah, well, this is exactly a question, because the questions are coming in, Martina, but I let them come a bit until you finish this explanation. But Quico Enrile is writing, how important is the size of the graft? It's not the same as the thickness, but know that this is a question as well. Yeah.
Yes, the dimension of the graft should be in relation to the thickness of the flap, because at the end of the surgery, we need to obtain a thickness of more than 2 millimeters. So we have to measure the flap thickness, and in most of cases are the thickness of the tissues when we are treating this kind of defect is very, very thin. We have, let's say, 0.5, 0.8 millimeter of thickness of the flap. So we need to add a connective tissue graft thickness in order to obtain at the end 2 millimeter of thickness. Why 2 millimeters? Because we know that in case of an inflammatory process occur due to plaque accumulation or to an improper tooth brushing technique, the inflammatory process occupy an area of 1.5 millimeters. So we need to have at least 2 millimeter of thickness of connective tissue between the external and the internal epithelium to withstand the inflammatory process and avoid a gingival recession recurrence.
Beautifully. In the meantime, and I'm enjoying it, and Hussam is also enjoying it. Your answer or your question or the same question was exactly answered the same way by Hussam Hassan in the chat. He says we need 2 millimeters at the end. So if we have 0.5 mucosal thickness, we need at least 1.5. And you add the great explanation that we need that to withstand any inflammatory processes. Great. So this is happening. And let's quickly answer also Hussam Hassan's own question. He's saying, hello, Professor Martina. You told us about the two-step approach, first the prosthetic removal and then the surgery. And he's asking, how much do you wait after the crown removal?
Yes, it depends, but on average, I can say that you have to wait between 1 and 2 months before starting with the surgery. And you have to check the patient every 2 weeks because you have to check that the provisional crown is not in contact with the soft tissue who are growing in a coronal direction. So in case there is a contact, you have to remove the provisional restoration and reduce it. And usually this pre-surgical prosthetic phase lasts 2 months. Obviously, the patient is not happy because he comes to me because he has an aesthetic problem, and I start to solve the aesthetic problem.
But making it worse.
Exactly. So usually patients are not happy, but they know that this long story hopefully will end with a nice smile. So.
Perhaps the check-in every 2 weeks also helps to kind of keep them close by and so no, this is really happening. Only 4 meetings and then we start for surgery. A practical question. Once you started to show the surgical video by Mahmoud El Bashir, and now he's using abbreviations and that's always tough on my side. I need to guess here. But he says, where exactly do we make the horizontal incision during making the CAF, a coronally advanced flap, I think? Is it like recession +1?
Here is not exactly like recession +1 because when we treat gingival recession around teeth, we only have a coronal advancement of the flap. Here we have a coronal advancement, but also a movement toward the occlusal aspect. So we cannot use exactly the same rule that we apply around teeth. We have to it's more precise, it's less precise around implant than around teeth. So we have to be reminded that we need to create the right trapezoidal shape of the surgical papilla. So we measure the recession and we check if with that rule we are able to obtain the right dimension of the trapezoidal papilla. In case not, we can change a little bit the position of the horizontal incision. And another difference between the treatment around teeth and implant is related to the length of the vertical releasing incision, which are longer when we treat defects around implant because we need longer coronal advancement of the flap, and most of the time we have more difficulties in the coronal advancement because of the scars of the previous surgical procedure performed to place the implant and sometimes to perform the guided bone regeneration in this area.
Exactly. Now that we are on the topic of all these measurements and incisions and all that stuff, do we need to take into account any differences that will occur after the surgery? Any healing or any recession, anything that we need to calculate for when we design this?
When we design the flap, we need to take in consideration, obviously, the depth of the soft tissue dehiscence that we are treating. We have to perform the 2-3 millimeters horizontal incision and the vertical one. And regarding the dimension of the CTG that we are going to place in the measured distal dimension, because we spoke only about the thickness and not about the dimension. The measured distal dimension should be measuring the distance between the two vertical releasing incision, because the connective tissue graft should remain inside the recipient bed. So the distance, measuring the distance between the two horizontal incision or the vertical incision at the level of the position, of the ideal position of the connective tissue graft, we have the mediodistal length. The apical coronal dimension is in relation to the presence of a buccal bone dehiscence. Because if we have a buccal bone dehiscence, we need to cover it with the connective tissue graft and apply the connective tissue graft above the buccal bone for 2 or 3 millimeters. So we have to measure the apical coronal dimension from the ideal position to the buccal bone. So the apical coronal dimension is related to the entity of the buccal bone dehiscence that can be present in the defect.
Exactly. Now I'm seeing some more questions coming in, but I want to make sure that we are fully understanding the approach. And I'm also curious to learn a little bit about the results, because obviously you wrote a very important paper about the results, but not only about the immediate outcomes, but also a bit about the more long-term or mid-term outcomes. Can you share with us?
This is the healings of the previous case at 2 weeks. We always remove the suture after 2 weeks, never before. Because we don't want to interfere with the healing. And after the surgical procedure, unfortunately for the patient, we still have a second phase with the short provisional crown, not in touch with the soft tissue, because we want to wait for the soft tissue maturation without any interference. So we still wait 3-4 months after the surgical procedure with the short provisional crown in position. And then it's time to start with another prosthetic phase, which is the soft tissue conditioning phase. And in this phase, we have to, let's say, guide this new volume of the soft tissue that we were able to obtain with our small connective tissue graft, and we can guide the soft tissue, pushing more apical the gingival margin in order to obtain the same scalloping of the gingival margin with the adjacent teeth, and squeezing the interproximal soft tissue in order to obtain a complete filling of the interproximal area. And this is the final result after this long story that starts with the pre-surgical prosthetic phase, then the surgical phase, and then again wait for the soft tissue maturation, and again second prosthetical phase. So it's a long story, but can provide successful results. Like in this case, you can see at 1 year the ideal position of the soft tissue margin and the increase in the soft tissue thickness that is completely able to mask the transparency that was present at baseline, and the increase in soft tissue thickness provide also this nice emergence profile of the implant supported crown from the soft tissue, and obviously the 5 years picture showing the stability in the long term of these results. So with this approach, it's possible to change the soft tissue phenotype of your patient, because now the patient has a different phenotype in this treated area. And this was the questions from the audience, and yes, I want to tell to the colleague, I don't remember the name, Gerrit.
It was Gerrit Heijkoop who also sent a question before we started. So again, if you're curious to do that, one of the next future topics, make sure you send in your cases to the EAO Bureau, and we can provide them to our experts. So this is the case of Gerrit.
Gerrit is luckier than the previous colleague, because in this case, I can tell, yes, you can obtain a nice result in this case. You can apply this combined surgical and prosthetic approach, especially because you have measured to the central incisor, you have an edentulous area, which represents a a big and nice papilla that can provide the right vascular supply for the coronally advanced flap. So in this case, I'm sure that with the connective tissue graft positioned at the ideal level of coverage, you are able to obtain complete dehiscence coverage with the proposed method. So he already knows how to perform this combined approach, and he will be able to obtain a nice result in this well osseointegrated implant, which is buccally positioned. And this is the reason why we have this aesthetic defect.
Exactly. That's what we're starting from and talking about tonight. Now, before we dive deeper into the results, let's take two questions from our live viewers who are more specifically about the provisional crown, because that's the key element in your approach. First, create some space for the soft tissue to grow. Lucretia Paterno-Holtzman is writing, "Hi Martina, great presentation. Is the provisional always screw or slash cement retained? And do you have any problems with retention since they are so short, quote unquote?"
Yes. The pre-surgical provisional restoration is cemented, and also the post-surgical provisional restoration is also cemented. And yes, sometimes we have some problem, and for this reason it happened that the patient come back with the provisional restoration that should be cemented again. And but yes, in most of these cases, is the problem is related to the buccal malposition of the implant. Also, at the end of the procedure, the definitive restoration will be cemented because of the buccal malposition of the implant. We use a screw retain provisional crown during the conditioning phase. In this phase, you can use a screw retain provisional restoration, but the pre-surgical provisional restoration and the final restoration are cemented in 90% of the cases because of the buccal malposition of the implant.
And I think that then also immediately answers Alfonso Gilles' question. He also says, "Great results, Martina, beautiful case. Do you prefer implant-supported provisionals or resin-bonded provisional bridges during the provisional phase?" I think the same argument goes, right?
Yes, no. It depends. The question is resin-bonded or?
Yeah, resin-bonded bridges as a provisional, or the implant-supported provisional?
No, in this case, I prefer to use implant-supported provisional, cemented provisional restoration. In other cases in which I decided to apply another surgical procedure, which is the platform technique with the submerged healing of the implant, and I have to remove before the surgery the abutment and the crown and place an healing screw. I prefer to apply, I have to apply a Maryland restoration bonded to the adjacent teeth, but because the surgical procedure will be completely different, will be a procedure with the submerged healing of the implant. So in that case, I have to apply a Maryland restoration. But in this case, I apply the short provisional crown, the cemented short provisional crown on the abutment.
Exactly. That is for now. Well, there's more questions coming in, but first I want to go to the results because I think you have some spectacular research findings to share with us.
Yes, because all of these cases were included in our paper, but not in our paper, in our two papers, because we described this procedure with the 1 year result. And we described for the first time this novel surgical prosthetic approach. And we were able to provide a very nice result in terms of complete dehiscence coverage and increase in soft tissue thickness in this first publication. And then we were able to describe complete coverage in 75% of the cases, which is similar to the result that we were able to obtain around teeth, which was quite new, let's say, in the literature regarding the soft tissue dehiscence treatment. And then we decided to publish the, not let's say long term, because 5 years it's a mid-term.
But in this field, it's quite long. Eh? It's novel research, but yes, in fact, it's midterm. Yeah.
Exactly, it's a mid-term result, and we were able to obtain an increase in complete dehiscence coverage. This can be explained due to a fact that is commonly called creeping. The creeping is something that happened to the soft tissue that have been thickened. When you thicken the soft tissue, they have the tendency to grow coronally. And if they grow coronally, they will increase the coverage of the implant supported crown. So we observe from 1 year to 5 years a further coverage of the implant supported crown due to the increase also in the soft tissue thickness. And this can be ascribed to the quality of the connective tissue graft that we use in this surgical procedure, because I didn't show you the harvesting procedure in the case I showed before, but the harvesting procedure in my hands is always the same. It's the free gingival graft harvesting procedure, because with this technique, we are able to harvest the connective tissue in the palate, which is immediately subepithelial, which is of the best quality because it's without fatty and glandular tissue, and which is more stable, and completely covering it with the coronally advanced flap during the healing. It will not shrink, but on the opposite side, we observe with time a further increase of the thickness of this collagen dense connective tissue graft harvested with this free gingival graft technique. So thanks to this quality of connective tissue graft, we observe this creeping phenomenon with a further increase in complete dehiscence coverage and thickness.
And Martina, does this then only happen at the site of the surgery? Hence, meaning, and is this so much that we then in 5 years have another aesthetic defect, or is it not as? I mean, do we need to think about that when we move on in the future with these patients?
I don't understand.
You mentioned the creeping that may occur.
Yes.
Is that then something that in the future can actually complicate the situation, because now all of a sudden here I have thicker or more soft tissue, or is it not that much of a margin?
Yes, okay, now you understand the question. Yes, sometimes you can observe excessive increase in thickness, and which is not nice from an aesthetic point of view. I totally agree with you.
And that's what we started with to base with, right? Yeah.
Exactly. Yes, but it's a complication which is rare. But from this complication, we learn that we don't have to increase the thickness too much, because at the beginning, we apply connective tissue graft, let's say sometimes of 1.5, 1.6 millimeter, but if the flap was around 0.8 or 1 millimeter thickness, at the end, you have too much thickness, and then if it grows with time, you will have an excessive soft tissue thickness, which is not nice. So now we know that we don't want exceed the 2 millimeter of thickness at the end of the surgery to avoid an excessive thickness formation with time. Yes, this is a good question.
Yeah. Good learning, yeah. Okay. We have a few more questions coming in. If you have questions to Martina Stefanini, please use the live chat. I want to start with Brenda Mertens, who's actually sending in 2 questions. Let's start with that last one, and I come to your previous question in a bit, Brenda. She's asking, so what are your post-operative advices to the patient for the healing phase in terms of brushing, interdental brush, etc.? What do you recommend?
During the 2 weeks immediately before the surgery, patient doesn't have to brush. Only rinse with chlorhexidine 3 times a day. Chlorhexidine rinse 0.12. And I don't want any trauma in the surgical area. Patient has to avoid to touch the surgical area, to chew in the surgical area, and avoid toothbrushing.
And did I hear correctly? Did you say 2 weeks before the surgery?
No, 2 weeks
After.
after.
I
Yes.
was thinking, okay, no, okay. So after, yeah, okay, clear, makes sense, makes total sense.
The patient should brush and do everything normally. Then after the surgery, they have to stop brushing for 2 weeks because I will remove the suture after 2 weeks. And in that period, avoid any brushing techniques and only chlorhexidine rinse. Mm-hmm. And as a medication, I prescribe some ibuprofen the day of the surgery and the day after. And I'm trying to reduce as much as possible antibiotic prescription in order to avoid and reduce antibiotic resistance, which is a big problem that we have. So in healthy patients, since the graft, the donor area in the palate is small, and also on the vestibular aspect, the surgical area is to treat only a defect, a single defect. I don't like to prescribe antibiotics. And after 2 weeks, I remove the suture, and the patient can start to brush with the ultra soft bristle and reducing the chlorhexidine rinse from 3 times a day to 2 times a day. And this for 2 weeks, 3 weeks. Then the patient can start with the not ultra soft, but soft bristle for 3 weeks. And then let's say after 3 months after surgery, the patient can start with the medium bristle and stop with the chlorhexidine rinse.
Exactly. And would you say after 3-4 months everything is normal then, or how long would it take till there's no precaution necessary anymore?
No, after 3 months after surgery, no precautions. It's
exactly.
Yes, because then we will start with the second prosthetic phase, with the conditioning phase, and the patient can start to use also interproximal cleaning device. For example, starting with the super floss, which is very gentle in this area and clean the interproximal area very gentle after the surgical procedure.
Clear. Let me quickly take Brenda's second question. She's asking, in which cases do you apply the submerged healing?
I apply the submerged healing in the case that I don't have enough interproximal tissues, and I cannot perform this pre-surgical prosthetic phase because I will not obtain, despite this pre-surgical prosthetic phase, enough interproximal soft tissue. So in these cases, I have to perform a submerged healing, which is the only way to increase also the interproximal soft tissue. But this is possible when the implant is not excessively buccally displaced. Because otherwise, if I don't have the interproximal soft tissue and the implant is too buccally displaced, as I show you at the beginning of the talk, I cannot do anything to solve the defect. But if the implant is, let's say, not excessively buccally displaced, and I have to improve the interproximal soft tissue, I can perform the platform technique.
Exactly. Now, here's a question from Manuel Carbajal, who came in a little bit back. Let's see if this is on topic or not. He's writing, Dr. Stefanini, do you have any videos treating implants on the area of the lower premolars? Because he's saying, I'm interested on seeing how you manage the tissues around the mental nerve. I'm wondering, since we are so much talking about aesthetic failure, are we still in the aesthetic zone?
I don't have a video on that area, um, because yes, we are speaking more about implant, let's say premolar in the, especially in the upper jaw is an aesthetic area, but premolar in the lower jaw is less aesthetic. And I don't have a case in the presentation to show you now, but I can tell you that when you are treating the lower jaw to avoid any mental nerve injury, you don't have to use the blade, as I show you in the previous video, to perform the deep split thickness incision with the blade to separate the muscles from the periosteum. If you perform this cut in the area of in the lower jaw at the level of the premolar, there is the risk to cut the mental nerve. So in this area, I always avoid the deep split thickness incision with the blade, and I apply the so-called gauze technique, because in this area the muscles are loosely attached to the bone. So if you push it in an apical direction with a gauze under the pressure of your finger, you are able to detach it and to see the superficial insertion of the muscles, so you can perform the superficial split thickness incision with the blade, but keeping the muscles that will protect the mental nerve in this area.
Exactly. And I think Hussam Hassan is on the ball again, because he's at the same time also writing in the chat, use a gauze around the nerve. So I think he's on par with us. Congratulations, Hassam. And Manuel is writing, thank you very much for these tips and advice. Now, we talked about harvesting tissue grafts. Now, obviously, this is a comorbidity that comes with the procedure, but there's always a discussion. Can we use alternatives? What are alternatives that we could use, or that you have used, or that you find beneficiary for that?
Yes, this it's an important topic, because I think that to treat our soft tissue dehiscences, in which you have an apical shift of the gingival margin, you cannot use any kind of substitute of the connective tissue graft, because in this case you need to stabilize the flap in the coronal position, and you need the real connective tissue graft. But if you have a lack of thickness of the tissue, if you have a buccal lingual deficiency, like in this case, let me show you the screen, because I want to show you this case with in this case, if you see at the position of the gingiva of the mucosal margin at the level of the first premolar is correct, because it's at the same level of the adjacent natural tooth. But if you look on the occlusal aspect, you see that there is this buccal lingual deficiency. And so the emergence profile of the crown is incorrect, and you can see the transparency of the underlying metallic structure. So in this case, you can perform a coronally advanced flap with a collagen matrix that will act as a scaffold to incorporate the blood clot under the coronally advanced flap that will completely cover the collagen matrix. In this case, it's the mucoderm, and the blood clot will remain inside the collagen matrix that act as a scaffold. And with time, from one side, the collagen matrix will degrade, and on the other side, the blood clot will mature and become new connective tissue. So using this collagen matrix, you see this is after 2 weeks at suture removal, and you start to see the increase in soft tissue thickness. And at 6 months, the matrix is completely degraded. So the increase in thickness that you have at 6 months is true connective tissue and deriving from this mature blood clot. And I think this procedure is predictable, and we published a paper describing case series reports treated with this technique and with the use of this collagen matrix to solve this buccal lingual defect. But again, I suggest to use the collagen matrix at that time only in this indication, to solve buccal lingual defect, but not to solve an apical shift of the gingival margin, because in this case, the only alternative is with the homemade connective tissue graft.
Exactly. Yeah, so it's very specific where you see the application of this, and in all the other cases, you would say,
and with this, to solve this kind of defect, I always apply the coronally advanced flap because it's my technique of choice. But in this case, you can also apply, for example, a tunnel approach, because you don't have to obtain a true coronary advancement of the flap. You have just to completely cover the collagen matrix, which is possible also through a tunnel technique in this case. So this can be an alternative also of the surgical procedure.
Exactly, very clear. Well, we covered quite a lot already. We covered indications when we should and should not treat, very clear. You showed us very clearly how your procedure works and explained it very well. Let me remind our audience, if you have questions, we are still live for a little bit, but it is about time to send it in, otherwise we finish off. In the meantime, Martina, we talked about science when you started. You showed this first image and you say, when we talk about aesthetic failed implants, everybody seems to talk about something else. Now, some of your more recent academic work has been on a classification of these cases. Can you tell us a little bit more about that? And especially also our researchers amongst the audience can hopefully learn how they can apply and use that in their research as well, so we can all build on a better body of knowledge and better research of that.
Yes, we recently published a classification of these peri-implant aesthetic defects, and it has been a huge work that we perform along with our friend in US at the Michigan University, and through a lot of brainstorming on Skype and on Zoom to obtain this classification, which is based on classes and subclasses. Classes are related to the position of the implant supported crown and the implant head, while subclasses are related to the papilla dimension, because these two aspects, the position of the crown and the implant and the papilla dimension, are the two most important aspects that we should evaluate in order to understand the final prognosis of the defects and in order to understand the surgical approach to treat this defect. And we have class 1, we have 4 classes. In class 1, we have the defect that I showed you before with the collagen matrix, in which we don't have an apical shift of the position of the gingival margin, but we have the buccal lingual deficiency. So class 1 is easy. In class 2, we have an apical shift of the gingival margin position, and we have the implant crown, which is in the right position. In class 3, we have the apical shift, but we have the implant crown, which is outside the curved imaginary line that connect the gingival margin of the adjacent teeth. So we have to remove the implant crown to check the implant head position. And we are lucky because in class 3, despite the crown is outside, we have the implant head, which is inside the straight line that connect the gingival margin of the two adjacent teeth. In class 4, unfortunately, once we remove the crown, we found that the implant is excessively buccally displaced, so is outside this imaginary line. And then we have to check the interproximal soft tissue. This is the best situation because we have a dimension of the interproximal soft tissue measured from the tip of the papilla to the ideal mucosal margin position that are greater than 3 millimeters. So we have a lot of interproximal soft tissue. In subclass B, we have less than 3 millimeter height of interproximal soft tissue. And in subclass C, we have the worst situation because we have one or both papilla which are at the same level or even more apically with the ideal position of the gingival margin. So with these classes and subclasses, we have a combination of defect because we can combine the position of the implant head with different quantity of interproximal soft tissue. And from this classification, we have our recommended treatment approach that include the famous combined prosthetic surgical approach and the soft tissue augmentation technique that we didn't discuss in detail tonight, but maybe we will discuss about that in another evening together.
Exactly, exactly. Well, thanks for sharing this. And I guess this is very important for further research. How do you see this classification now moving forward in the future? How would you like our viewers and our friends of our viewers, because obviously we need you as viewer, as an ambassador to tell everybody to go see this video in recording. How do you intend or would you like to see the future use?
Yes, we would like, since in this classification, we also suggest treatment approaches, we would like to publish further results in which we are able to relate the success of the procedure in relation to the proposed classification. I think that this next step will be very important because we provide a classification, we recommended a treatment approach, and the next step is to provide the result of these suggestions.
Exactly. So everybody who is researching soft tissue surgery or soft tissue management in this aesthetic zone should definitely take a look at these papers and see if they can also help you build more evidence and more data, right, in this using this classification.
Exactly.
Exactly. With that, I take another look at our live chat and I see that we are drying out. I mean, we're doing well. We see many thank yous already. So I think, Martina, we were able to really well describe both the topic, the challenges, the limits, the surgical approach, and the data you have found. So let me remind our audience once again, if you have an important takeaway from this session, please share with us in the chat what you found, how it has helped you. But with no further questions, I think we're slightly going to round up. But not before, Martina, obviously this topic is not as straightforward as we make it perhaps seem tonight. Because as we said at the start of the session, there's a lot to debate about in this field as well. So let me invite all our viewers, if you haven't done so, please take a look at the EAO online library, where you can find all the recordings of the EAO Digital Days, amongst which is the primetime debate also with Martina, Marcus Oestlers, Ronald Jung, and many others, let's put it like that. And yeah, exactly. And you can have a look at that, and that's just one of the sessions. So if you haven't done so, please consider a membership of the EAO. Look at eao.org for all the other benefits. Martina, any famous last words that I can ask you for tonight?
I hope that my colleagues understand the importance of soft tissue management and understand the reason why these kind of defects happen, which is mostly our bad implant positioning. So from that, we have to learn how to prevent these soft tissue defects. So maybe in another occasion, we will discuss about how to position an implant in the proper way, managing bone and soft tissues at the same time, because this is the most important aspect to prevent soft tissue dehiscence occurrence, because gingival recession occur around teeth that are already in place, but soft tissue dehiscence occur in implants that we place. So we need to avoid that this can happen.
Exactly. Well, that's very clear. And you make a few nice hooks to other stuff. If you're interested in this topic, please also check on EAO's YouTube channel where you're watching right now. The EAO Just Ask with David Nissan, which is also about soft tissue management. And I think he also already looks a bit more in that implant placement phase. And as you said, maybe in a next edition, if you want to make sure that you're part of a future edition of EA Just Ask Live, make sure you hit the subscribe button on YouTube right now, because you'll be the first one to know and to get a notification when a new session is live or is planned to be live. So, and of course, let me remind you once again, as soon as Martina and I hit the stop button here tonight, you can then watch this entire session in recording. Please share it with any friends or colleagues who might find this interesting and beneficial, because the more we learn, the more we share, the better implantologists we will become. With that, Professor Martina Stefanini, thank you very much for joining us live from Bologna tonight. I hope this was a good experience for you.
Yeah, super nice experience. So thank you very much for inviting me. And I want to say out to people from all around the world that were with us tonight.
Exactly. Well, there's a lot of praise in the chat. We go read it together in a minute. But for now, I'm saying thank you to everyone. And I'm looking forward to see you back next month at our next Just Ask Live.
Bye.